Hi, everyone. It's Jean Sachs, the CEO of Living Beyond Breast Cancer. And I am here this morning with Dr. Don Dizon, a medical oncologist specializing in women's cancers, a professor of medicine at Brown University, and director of women's cancers at Lifespan Cancer Institute in Providence, Rhode Island. Don, thank you so much for being with us today. So what we did last night was we put a call out to our community and asked for pressing questions, things that they wanted to ask Dr. Dizon in the wake of this COVID-19 crisis. So I have a bunch of questions. I'm just going to read them off and hopefully we can give our community some answers. And I just want you to know that we posted that and we got so many questions right away. So we know there's a lot of anxiety out there.
Yeah.
So let's just get started. There's a lot of questions about who is immune compromised. So could you kind of give the quick overview of who with a breast cancer diagnosis do you consider immune compromised?
Well, I think the shortest answer to that question is anyone who's receiving standard chemotherapy, because chemotherapy does reduce your white cell counts, and that's the very definition of being immunocompromised. Now, what's important to know with this infection that's going through communities is that it's a viral infection, and one of the hallmarks of the infections is lymphopenia. So it's actually reductions, not in the cell lines that are affected by chemotherapy, which oftentimes will reduce the white cells and produce a neutropenia. So the importance of all of that is that neutropenia, neutropenic fever, neutropenic sepsis typically is bacterial. But what we tend to think of as the risk, even with COVID-19, is that if your immune system has been impacted by treatment, whether that's the neutropenia or globally a pancytopenia, which is when all the cell lines are depleted, that meaning your platelet counts might be down, you might be anemic, and you might have low white counts, it does make you less able to fight off any kind of infection than if you had normal cell lines. But essentially, if you're on therapy for cancer, whether that's chemotherapy, whether that's anti-HER2 treatments, whether that's immunotherapy, we are worried about just a relative neutropenia that will put you at lower abilities to fight a COVID-19 infection.
So what about for those in our community who have had early stage breast cancer, they are completed with their first line treatment, but they may be on an aromatase inhibitor, tamoxifen,
right.
Lupron. So do these drugs have any role in compromising the immune system?
No, it doesn't. And I think one of the things we're just not that clear about yet is whether or not just having had a cancer makes you more susceptible to a more severe infection with COVID-19. Now, the data that sparked a lot of this came from China, and it was published in The Lancet earlier this month, I think. And it did show people with a history of cancer and people on treatment for cancer had a higher risk of a severe infection and also of death due to COVID-19. But when you look at the cohort that they had in China, these were also patients with a lot more comorbidities, and they also had a history of smoking, and they also tended to be older. So, based on that singular data set, having cancer as a medical history issue did have an impact on death from COVID-19, but so did having hypertension, having cardiovascular disease, having diabetes, and having respiratory problems. So again, it's hard to, right now to pinpoint just having cancer. And if you're otherwise healthy, are you at an increased risk? I think all of us are taking the more cautious interpretation of that data and saying, the rules that apply to the public still apply to you who have had a history of cancer and are not with any evidence of that cancer. You still need to practice the hand washing, the social distancing, the cleaning of the surfaces. These are still very important because we have no guarantees at all that if you get sick, it won't be severe.
So what about for those who have finished chemotherapy and you're not taking any other treatments? How long are you immune compromised from sort of that last treatment?
Right. Usually you are able to recover a fairly normal immune system within 4 weeks of your last chemotherapy, depending on what that is. I typically will tell people, 3 months later, you're fine. There are no restrictions on you. You can, go to the dentist. You don't have to wear a mask outside, things like that. But definitely at 3 months, as early as 4 to 6 weeks after chemotherapy. What's nice about modern chemotherapy for breast cancer is that it's not as toxic as it was, 20, 30 years ago. Plus, we're also being much more precise in who requires chemotherapy and who's going to do fine even without it.
What about those who are either actively in radiation or just finishing radiation?
Yeah, that's a big issue right now in terms of radiation, timing of the start of radiation, and whether or not it should be delayed. I think most cancer centers are still going to complete radiation plans on people undergoing treatment. Whether or not, again, that predisposes to more severe COVID-19 infections is not clear. I did get a question on social media about if someone has fibrosis of the lung due to radiation, does this set them up for more severe infections? And again, that's a big unknown. But if you look at the presentations, the classic presentations of COVID-19 in the lungs based on CAT scans, for example, which, by the way, are only present in about a quarter of cases, you're seeing peripheral inflammatory changes in, working lung fields. No one has that data set on patients who had prior radiation and the natural history of a COVID-19 infection. In fact, if you look at the folks who are getting very sick right now, the demographics in the US don't seem to be mirroring that in China and in Italy. We're seeing younger patients get very sick and requiring ICU care. So, where prior medical therapies for cancer is going to play out is not clear because I don't think the demographics in the US are mirroring what we know already.
Right, so we're still learning a lot. Dr. Dizon, you may have said this and I might not have heard you, but did you address the patients who are taking the newer CD4K6 inhibitors?
No, I didn't actually specifically mention the CDK4/6 inhibitors. Again, these are pretty precise and targeted treatments to a pathway. They do cause myelosuppression. So I think in general, thinking about how these oral therapies are going to or might impact risk, I would fall towards CDK4/6 and lumping them together with chemotherapy, because again, they are causing side effects that do impact bone marrow.
Right, thank you. I don't know if you're going to be able to answer this question, but we did get it. If someone who is actively in chemotherapy does contract the virus, do you know what they can expect to happen?
No, unfortunately we cannot, we cannot predict at this point what would happen. I can say it's a concern within cancer centers is that given the high unknown population of asymptomatic carriers, it runs through all of us that, are we running into a situation where we're actually exposing people because they have no symptoms of COVID-19 but are carriers of this. At this point, we have no idea what would happen if patients got COVID-19 and were also on chemotherapy. I think there's a bunch of variables that might play into that. Where they are in their cycle, are they natoring in terms of, are their white counts on the way down? Are they recovering at the time of their infection? And also, the comorbidities and certainly age seems to play a factor in how COVID-19 affects people and their severity. I think it's just very hard to predict. So I certainly wouldn't say it's appropriate to believe that if you get COVID-19 and you're on chemotherapy, that you're going to die from this. We are worried that the course might be very difficult. We are worried that there might be an increased risk that you won't do as well as someone your age without a history of cancer. But again, there's just so much we don't know.
So this question came from someone who's living with metastatic breast cancer, but given what I'm learning from you this morning, I think it actually would apply to anyone who's in active chemotherapy, whether they're early stage or metastatic, which is, do you think those people will be advised to stay isolated until we develop a vaccine? So this is more of a forward-looking question.
No, I mean, I think the hallmarks of the public health response, which we have not yet seen in the United States, is, this whole notion of sort of flattening the curve is really trying to get a handle on the infectivity and ensure that we can go on with our lives, even though this infection is in the communities. So universal testing will find those folks, right, who are exposed, who have an infection. That can lead to the second part, which would be to isolate those folks into self-quarantine, but also trace the people who they were also in contact with, so we can then target them for testing and potentially for isolation. Right now, we're in a situation where for a large swaths of the country, in fact, I would probably say the majority of this country, we are operating with blindfolds on. We have no idea who's been infected. We're looking for, areas where the infections appear to be gathering momentum, just like in New York City and New Orleans. But that is really hindering the response. So you do not have to stay in quarantine until there's a vaccine, because realistically, we're talking about a year from now. What we're hoping to do by flattening the curve is get to a situation where we can then roll out better, more proactive testing, leading to isolation and then tracking of potential spread. And that we're just not there yet. But I think once we get there, we will be able to sort of live a more normal life.
Yeah, that's what we're hearing.
Yeah.
So there's a lot of talk on social media, and we know this is happening, that some patients, their treatment is being delayed.
Yeah.
Or they're triaging patients and really trying to decide, can you continue? So how are you managing that? And what do you have to share?
Well, so at our institution, we are operating we're operating with normal rules of engagement. Let's put it that way. We're not closing the infusion unit. Everyone who has started on treatment, we're aiming to treat them on time. So in terms of delaying chemotherapy, we're not doing that. There might come a time when resources become stretched, or, as is happening in other parts of the world, cancer centers close so that we can manage an aggressive response to COVID-19. Fortunately, we're not there. We're thinking about, we're obviously doing what many centers are doing, which is limiting visitors into the infusion unit, limiting family into the infusion unit, looking at who needs to be seen in person versus video consults, and really trying to identify those patients who need to come to the hospital to be seen, cleared, and treated with intravenous therapies. So right now, it's really a provider-specific discretion, provider and a patient making a decision. Those decisions might be, should we use IV meds, or can I prescribe an oral regimen for you, which will buy us time. If you're stable on therapy, can we reduce the number of treatments you need versus continue to the full course. That's an active discussion point right now. But I think at the end of the day, it's really important for people undergoing treatment, particularly in infusion units, to know that this is still a shared decision that's being made at the level of the patient and her provider.
We have heard about surgeries being stopped.
Right.
We've also heard
Right.
maybe people who would have been getting surgery first
Right.
switch to chemo first.
Right, and I think there is a movement to stop elective surgeries, and so the question on the table is the interpretation of elective. At the Lifespan Cancer Institute and the Brown University institutions, cancer surgeries are not elective. Okay, so those will be scheduled; those will continue to go on. What is being pushed back? Folks who have, a triple negative breast cancer or a HER2 positive breast cancer that is not exceptionally small, and there's some wiggle room here. It might be, anything smaller than a 5 millimeter cancer will go to surgery. Everything else will go to neoadjuvant chemotherapy, or it might be at 1 centimeter. But remember, all of these measurements also take into account what does the breast look like for this patient, because that tumor to breast ratio is really the determining point between a mastectomy and breast conserving surgery. So, even with the most broad guidelines, there has to be room for individualization. But that's the real impetus across the country, is what is the institution's perspective on elective surgeries? And based on that, how do we want to roll out surgical decisions? At our institution, elective cancer doesn't fall into that elective category. We are using neoadjuvant chemotherapy. We're being very, very conscientious about who gets the surgery and who should get neoadjuvant chemotherapy or neoadjuvant endocrine therapy. Again, it's coming down to the individual basis and shared decision making still.
So if a patient is told by their doctor, we're going to delay your treatment a little bit, or we're going to delay your surgery, they should feel confident that these doctors are really thinking through every case, right? You're looking at everyone and figuring out how to triage. And
right.
We've certainly heard from some women who are really panicked because things are.
No, that's definitely happening. I can sense the panic even on social media. And I can't speak to how folks, say, in the metropolitan New York City area are handling their cases, or in Seattle, for example. And I think so much of this is going to shift depending on the number of cases in communities. So there is not going to be a national policy. This is all going to be center by center, city by city, and this is what we're looking at, and this is how we're responding. But in every case, I think a patient should still be empowered to ask the question, how is this going to impact me and my cancer? Is it going to impact my chances of cure? What is safe? And again, there is no singular answer to any of those questions.
Well, I want to thank you so much. And I just want to take a minute to say that I know you and all the healthcare providers are really on the front line of this. And we are so grateful for you and, thinking of you all the time and wanting you to stay safe. At Living Beyond Breast Cancer, we really understand that this is a very, very tough moment. So please know we're surrounding you with, well, if I could pray, I would do that, but I'm surrounding you with light and love. And I hear that over and over again from everyone I talk to.
Yeah, and thank you very much. And again, it's like, our thoughts are always with our the people we're treating with cancer first. It's with our families, with our colleagues and our friends. And we're really, putting, the priority on my health is probably the last thing I think about. Because, this is what we were trained to do, but everybody needs to try their best to stay healthy.
Yeah, we need all of you to stay healthy. So thank you again, and thank you to everyone who's listening. And remember, Living Beyond Breast Cancer is here for you in lots of different ways, so stay connected with us.
Thank you very much.